coming from the ART kingdom, but to be honest, I spend the most of my life in the ultrasound kingdom, because in ART we are continually doing scans to check the follicles, scan to check to do the pickup, and scan usually to assess the endometrial thickness. The endometrial thickness is the biomarker, the most used biomarker in assisted reproduction. 100% of the patients that receive an embryo have assessment of the endometrial thickness. So it's, well, very, 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 very common and very controversial that we are going to see. Sometimes the patients say, well, what is the, before doing the scan, what is the objective, or what is the best endometrial thickness? And I say, let me see after the scan, because sometimes we can, say to the patient that this is the objective and really the patient is different, but you are going to do the embryo transfer in any way. But this is the beginning of the history in 1990. This is the publication of Gonen, that he failed to find a pregnancy in endometrium under 6 millimeters. So it was very clear, because if you have less than 6 millimeters, for sure you are going not to have a pregnancy, theoretically. And taking into account that Juancho Garcia Velasco explained Monday here that we have no a good proportion to the patient to improve the endometrial thickness, not only Juancho Garcia Velasco, but even the Canadian Fertility Society say that the Adson that don't work, doesn't work in this kind of patient. We will discuss afterwards. Well, we can use this limit, 6 millimeters. It's thin enough to consider to recommend to the patient to giving up and to move to the surrogacy or something like this. But you know that this is not the truth. And we know that a good embryo can implant in a very thin endometrium. This is a case report of this year. Even a good embryo can implant in the cervix, and a good embryo can implant even in the spleen, and even in a T-shaped uterus. So a good endometrium can implant in endometrium, can implant in everything. So this is not a good recommendation that 6 millimeters is the cutoff to consider that it's not worth it to do anything with this patient. But, we must try to find a cutoff to recommend the cancellation of the treatment and try again to obtain a better endometrium, or even to inform the patient about the poorer prognosis than expected, and to stabilize the best strategy with the patient. But first of all, we must try to consider it in an endometrium with a normal thickness, the things happening in a different way than an endometrium with a very thin endometrium. And we have some publications about that the blood vessels are different, that the expression of the vascular endothelial growth factor is different in a thin endometrium. Even the transcriptomic could be different in a thin endometrium, or the vascularization in a thin endometrium is lower. That this can explain that we can find different things. But if we go to the data, to the big data, in this publication of Leo, 40,000 embryo transfer, when we consider fresh embryo transfer, we consider that 8 millimeters could be a good cutoff, and with frozen embryo transfer, 7 millimeters could be a good cutoff. This is another study where the plateau starts in a different cutoffs. For example, with more than 96,000 embryo transfer. In the first embryo transfer, 10 millimeters start the cutoff of the pregnancy rates, and in frozen embryo transfer, 7 millimeters. So could be discordant in one or another way of preparation of the endometrium. This is the meta-analysis of Krasniqi. In all the cutoff, the situation is statistically significant. but the sensitivity specificity curve is horrible. This is a constant in all these studies with the endometrial thickness. And this is another meta-analysis of Gao, and you can see here that considering 7 millimeters, the probability of success is lower under 7 millimeters, but this is not statistically significant in prospective studies, only in retrospective studies. This is another meta-analysis, a recent another meta-analysis. The curve is horrible. The pregnancy rates are different when we consider retrospective studies, but not when we consider prospective studies. This is another study, a recent study by Zakarian, considering that the ROC curve is absolutely horrible with no cutoff that can distinguish or have the best sensitivity and specificity. And if you go to the numbers, they find that even under 6 millimeters, the pregnancy rates are more or less acceptable, or in this case, with normal pregnancies. And this is probably the last study with a very good design, because it's practically 1,000 single embryo transfer of haploid embryos, considering that we can avoid the bias of the embryo, because all the embryos were haploid. And we are lucky because the main author is here with us, Barry Sata. And it was very controversial because considering the reference between 4 and 6 millimeters of the endometrial thickness, the thicker endometrium was not with better results than with this thin endometrium. So at the moment, this situation remains controversial. And this is the last meta-analysis. It's well, more or less the same, that we have more meta-analysis than analysis, but the results are not especially different. This is another meta-analysis considering IUI. I consider the difference between different drugs to stimulate the ovulation. And with gonadotropins, the results were no different than clomiphene, and we failed to detect a constant impairment of the probability of success in when the endometrium is very thin. Okay. And what about the pattern? The pattern is, the history of the pattern starts practically at the same time. This is the work of Grunfeld in 1991. And describing the different kind of patterns. Well, this is the concept of high resolution in 1991. And the result was the endometrial thickness was not statistically significant to prevent the pregnancy, to predict the pregnancy. And the pattern, when the pattern was not trilaminar, the results were worse than when the pattern was trilaminar, so the pattern mattered. And this is another study about the unimportant question that we are more worried about nowadays, that is the complication of the pregnancy and the end of the pregnancy, and with things that we do to prepare the uterus. And we consider that the situation in the uterus could be not predict the pregnancy rates, but can predict complication at the end of the pregnancy, like hypertensive disorders. And this is a systematic review and meta-analysis considered the hypertensive disorder, the gestational age, and practically all the parameters are worse in patients with thin endometrium. And this is another study published recently considering the risk factors of placenta accreta, and the only factor that was statistically significant was the thickness of the endometrium. So when you have a very thin endometrium and you obtain a pregnancy, the recommendation is to send a message to the obstetric kingdom, because probably during the delivery or at the end of the pregnancy, they are going to have problems. And finally, this is a very, very recent publication about the thick endometrium. They consider that when endometrium is very thick, over 12 millimeters, they have more hypertensive disorders at the end of the pregnancy. So the topic can change, and well, probably how thick is too thick could be another topic, but this could be for the next edition of the Hartus. So in any case, don't be crazy, because well, with the endometrium, Luis talked about 12 millimeters could be the optimal. We are going to discuss the situation during the discussion. But, well, we have no ceiling. We have no limit that endometrium is too thick to consider that the prognosis is worse. And finally, to consider it, it's more than a personal opinion that evidence-based data. One thing is to debate about evidence, and one thing is to make decision. Because we do the scan, and we must make a decision with the patient and decide to cancel the treatment, to go ahead to inform the patient about the prognosis and everything. So, like a proposal, when we cope with a thin endometrium, the first thing is to inform the patient that to know that the pregnancy is possible and likely, okay? It's not the end. That we consider the publication of Liu. In this publication, an endometrium between 4 and 6 millimeters have about 25–30% probabilities of pregnancy. 25–30% of probability of pregnancy is the probability of pregnancy is a woman of 38–39. Okay, so it's not the end, because sometimes it's, well, we have no life with this kind of endometrium. The pattern matter. That in case that we must check the three-laminar pattern is going to be important to take into consideration. If not three-laminar or under 6 millimeters, visit other kingdoms, okay? Or revisit other kingdoms, because it could be important to rule out that everything is okay in the uterus, and we can discuss about afterwards. And if hysteroscopy and ultrasound are not normal, we should proceed with confidence and go ahead with the embryo transfer. We consider that we must reassure to the patient that it's not a crazy thing to do embryo transfer when the endometrium is under 6 millimeters, in case that we have three-laminar and everything is okay with the hysteroscopy and the ultrasound. And finally, well, just an opinion to show my gratitude to the colleagues in my group that are in charge of the image, of the hysteroscopy and ultrasound. We consider that the ultrasound and hysteroscopy must be integrated in fertility clinics. I think that this is quite important. And of course, with the integration with expert surgeon with hysteroscopy, but must be integrated at least the diagnosis of the hysteroscopy in a fertility clinic, because I think that it's the only way to do our best for the patient. Thank you very much for your attention.
Thank you very much.